to start us out in our content, just to give you an overview of kind of what this is going to look like. I know we went through our objectives, but just to give kind of a 10,000 feet view of what we're doing today, we're going to start with talking about theories of change, behavior change specifically, but as you see here, we'll also be talking about some cognitive domains of change and affective domains of change. We're doing this because, and this applies to things beyond reproductive health and sexual health. When we're working with people and talking about making a change, hopefully for the better, things like quitting smoking or exercising more, or using condoms to prevent STIs. Change is very personal to people, and so we really want to be able to understand where our patients are coming from, realizing it's dynamic. They're going to be in different places at different time. And like Tammy said, also having some strategies for working with people at these various levels of change. Now, this section is very kind of theory heavy, so we're going to try to bring some concrete examples wherever we can. And don't think that all of this has to be happening, in the back of your head right off the bat. This is something I've been doing for, many years. I primarily was working with students who got in trouble for drinking alcohol, college students. So you can imagine how fun that must have been in New Orleans. Got a lot of work. But it's something that does take some time. So we're going to lay it all out here. And then as we go forward with our relationship with you, we'll check back in about how this approach, using these skills and these strategies works for you. And we're able to pull, future trainings, we can pull in some more of this stuff to just help you integrate it into your work. So again, when we're talking about change, generally things break down to these three categories of how you think about making a change, how you feel about making a change, and then the actual behaviors that make the change. So that's kind of our first series of buckets we're putting things in. But we want to talk about this theory called the trans-theoretical model. This has been around for a while. Tim, you can go to the next slide. Might be a little slow. There we go. So this has been around for a while, and originally this model was mainly used when thinking about substance use and making behavior change around that. And so you can see there are these different categories here, these different stages. This is also sometimes called the stages of change model. We're going to go through each one independently, but just to kind of pull it back to what we were just talking about with the domains of change, depending on what stage a person is in their thinking about making the change or making the change, you might be working with different domains. So if someone is pre-contemplative, they're not even thinking about making a change, you're probably going to focus more on, the cognitive or the affective domain. So thinking about it and like what your feelings are. But then as you get later into this model, so maybe in the preparation, the action, there you're maybe going to be focusing on more of the behavioral piece of it. Again, all of this, humans are complex. And so while it would be great if the progress went in this linear fashion, you can see with all those messy arrows on the other side that people go back and forth between these changes or these stages. The part that's most important, though, I think, about identifying the different stages, which we're going to go through in a sec, is what your best strategies are based on that stage. So let's start with pre-contemplation. Just that first. So pre-contemplation, if you thought about someone talking about pre-contemplation, they might say something like, I don't have a problem. I'm not interested in making a change. So you could think of someone, let's say you're talking with a young person who has just started smoking and it's like the cool thing to do. And they are young, and so they think to themselves, I don't need to quit. I don't smoke that much. I'm young. I'll quit further down the road. So for this person, they're just not even thinking about making a change. And if you tried at this point to really push someone or even strongly encourage to make that change, you're going to get a lot of resistance because they're just not there yet. So some strategies that you can use when working with someone in the pre-contemplation stage, ask permission if you can talk about this. Is it okay if I give you some information on this this topic? Or is it okay with you if we have a conversation about it? it gives them the chance to say no, and you have to respect that as well. But it also helps build that trust and rapport, and shows that you really respect the autonomy of the person that you're working with. Because again, sometimes people just aren't there yet, and so it's really hard to move them if they're just not even ready to move. Something I have always liked using is just asking, what brought you in today? You know, I know when you're doing intake with patients, it's often a lot of, you know, yes, no questions, or when was your last period, or, you know, very kind of distinct answer questions. But really starting with what brought you in today, you can get a lot. If you get a chatty person, sometimes people are not that chatty, but if you have someone that can really tell you, you know, you're going to hear from them right off the bat what's most important. They'll probably lead with that. Not in all cases, which again is why we do these screening questions, because there could be some underlying things that could be addressed as well as their main concern. But just starting with that great open-ended question, what brought you in? Another tool that you can use are self-evaluation rulers. So this is giving the patient an opportunity to tell you where they are. Usually we say on a scale of 1 to 10, in terms of importance of making a change, how confident they feel that they can make that change, and their motivation. You could get very different answers in terms of the scale for all of those. Putting that picture together can give you a really, or putting all those pieces together can give you a really good picture of just how ready that person is to, in this case, even start thinking about change. And then even if they walk out that door, they aren't even thinking about making whatever the behavior change is, keeping that door open, checking in with them the next time you see them. Because again, things change from time to time. So a lot of strategies to work with that person who's not yet ready to start thinking about change. Which then leads us to our next, so actually, no, I think we're going to talk about the self-evaluation ruler. So this is where, you know, I just mentioned, you can use a scale of 1 to 10 to say, how ready are they with these different elements, importance, confidence, motivation. The important part about using a method like this is to say, okay, Tammy, on a scale of 1 to 10, you know, how confident are you that you can get more sleep at night? So a 2, okay, that's great. So 10 being most important, and you're at a 2. So you're not a 1. What brings you to a 2 but not a 1?
I am under so much stress, I can't even sleep at night.
So what do you think it might take you to get to a 3 or 4?
I need to win the lottery.
Most of Tammy might end with, we need to win the lottery, that would solve it. Thank you, Tammy, sorry to put you on the spot there. But what you're really trying to do with this is, you know, obviously someone that's at a 10, they may not be thinking about it in the same way that other people would. Usually people, they're going to be kind of somewhere in the middle. And you want to ask them the question, okay, well, why weren't you a lower number? Maybe just going 1 number below what they said. I'm a 5. Okay, well, why not a 4? Like, what makes you a 5? That gives a person the opportunity to talk about what they are doing, you know, where they are confident. It may not be the top of the scale, but it's going to give them an opportunity to talk through, okay, well, you know, I've tried to go to sleep earlier. You know, I've tried not to look at my computer screen right before I go to bed. And then you take them to that next step. Okay, well, what would it take you to get to a 6 or a 7? And then that gives them the opportunity to talk about what realistically they think they could do to raise that confidence or importance or motivation. So it kind of sounds like a lot of steps, and I will acknowledge through this whole training, we know how pressed you all are for time. This is something you can do pretty quickly though. And you don't have to do it for all of these different aspects. You know, if it's really confidence, you know, that person really wants to change, but their confidence is just really low, you can just do a confidence scale. In the past, when I've had more time to work with people, I would do 2 of them, because let's say you do importance and the person's like, oh my gosh, I'm a 9. It's so important for me to make this change. Then you would ask confidence and they would say, but I'm at like a 3. So then that helped me know I don't need to explain or, you know, try to get this person to see how important it is. They're there. Where they need some support is their confidence. So this is one that if you haven't used it, sometimes it takes a little while to kind of get the hang of it, but I think it's a really, really valuable tool. Okay, so the next stage we're talking about is contemplation. So this is a person that's ready to make a change, but, and this is what's key for this stage. If you hear someone say something and they say but in the middle, they've just told you two things, and those two things are probably on the opposite side of, you know, the pros and cons of making the change. So anytime you hear a but, pay attention to what they said first and what they said second. And try to see if you can maybe flip the script, because if someone came to me and said, I know I should make a change, but I'm scared, I could reflect like, you're really scared to make the change. And then they would say, yeah, and they would keep talking about why they're scared. But notice if I said something like, so it sounds like you're scared to make the change, and at the same time you realize how important it is for you to do so. What I've just done is flipped it, so now they're ending with the part that is what they're expressing that they know they should do or they want them to do. So that's another little tip and trick that I've learned over the years that really helps move these conversations forward. If you end on, you know, kind of the status quo or the thing that they're afraid of, you often will get in a rut where they just keep convincing themselves why they're scared and what's getting in the way and all of that. You want to move them more towards the change talk and what they could actually do to make those changes. So it's really weighing the pros and the cons, weighing the ambivalence. Some strategies here is to explore that ambivalence, and really get them to, you know, make that connection for them where there's some discrepancy. If they're on both sides, say, okay, well, that's kind of different. So tell me about, you know, what's on either side, and help them with this decisional balance exercise that we're going to talk about next, that will hopefully tip the balance in favor of change. Now, again, we're acknowledging here that change is positive health changes. There are some changes that people make that are very personal, and I can't say one way or another what's the better option. But if we're talking health behaviors, we know that like quitting smoking is a positive change. There are certain things that are pretty unequivocal in terms of change. And so that's what we're really talking about here. So again, you can use the self-evaluation rulers for this, share information. If it seems like, you know, oftentimes it seems like, oh, a person isn't making a change, they just don't have all the information. So I'm just going to give them information and then they'll make the change. And we acknowledge that a lot of these skills are probably just ingrained, these strategies, based on you doing the work that you're doing. So, you know, it's helpful for us to kind of just do an overview of this so that everyone's like on the same page as we get to talk more specifically about reproductive health and sexual health. But yeah, I mean, a lot of this stuff is you know, how healthcare is provided. And it really has changed. I mean, I haven't been in this field for as long as some people, but you know, there really has been the shift more and more these days to that patient-centered care, where it's really, you know, working with the patient to develop a healthcare plan that works for them and that they're going to be able to follow, as opposed to me just saying, you need to do this because of this, this, and this.
Right.
So it's exciting to see that shift. Okay, so let's talk about the decisional balance exercise. This one I've found can work sometimes as homework if you have patients or clients that if you don't have a lot of time and they're really struggling with something and they need some more time to think it out. The way that I've done this in the past is to actually draw like a little, you know, 4 squares, and then you basically have the pros and the cons about maintaining the status quo or making the change. And you have them kind of do each box. If you're doing it verbally, this is the best sequence of questions because you're starting with, you know, what are the good things about not changing or maintaining the status quo? People often they're not expecting a question that's asking about like, what are the good things about keeping doing the thing that you're doing that we're trying to change? So it can be very disarming and show that you really are you know, curious about where they are and how they feel about things. So you start with the good things about not changing, and then what are the downsides about not changing? Then moving to the questions about changing, starting with the downsides, so they get to get all the barriers and obstacle, you know, stuff out of their system. And then again, you end on this positive note about what would be the advantages of changing. And, you know, if you are doing this in a verbal way, really asking some exploratory questions, some open-ended questions around this to keep them talking, keep them looking for solutions that will work for them. So I think that this is really, really helpful when someone's really struggling with that ambivalence in the contemplation stage. Okay, so now they're ready to make the change. They're gonna do it. The important part about this stage is this is someone that's gonna imminently make the change, not like, it's the difference between saying, okay, well, as soon as this week's over, I'm gonna start eating healthy and I'm gonna start walking every night, versus, yeah, my birthday is in April and that's the time I'm gonna make some change. It's something you're gonna do that you're like preparing for right now, not something that in the future, because that would still be more contemplation. So here, working with the person, some of your strategies would be helping them make that plan, because it really helps to have some concrete steps. It's also important to see what they've done similarly, you know, if they had tried to make this change in the past, like what had worked for them, where were those barriers? You know, very infrequently are, you know, someone wants to make a change and they make it and it's over and done with. It often takes some time and it takes a few tries to get something to really stick. So being able to tap into for that person, and one way you can do it is, you know, especially if they're having a hard time coming up with ideas, saying something like, well, you know, I've worked with other clients who have said, this worked for them or this worked for them. What do you think? How would that work for you? So if you need to get them talking, that can be a way to do that. Acknowledge that there will be relapses. It's natural, it's normal, you know, but how can you ensure that that's not going to totally derail someone? Because I'm sure many of us have had that experience where you're doing great, you miss one day at the gym and then it's done, it's over. I hope I'm not the only person that happens to. So there are going to be, you know, some relapses and some slips, but kind of having a plan for that upfront is really important. So really having that plan, and having the steps be incremental in enacting that plan, because it can be really hard to make one big change, much more attainable to do those small incremental steps on the way to the big change. Okay. Our second to last stage is action. They're doing it. But it still can, there can still be some, you know, challenges in the way of making this change your habit. Especially I think of people who have really struggled with tobacco or alcohol use, where it really is day by day making it through and sticking to your change plan. So, you know, again, in this stage, you know, you want to be there for the person as they're making those incremental change. If they need to, Tim, can you do next slide? Make a plan for, there we go. Revise your plan, you know, especially if it's something where, I know last time I went to the doctor, we're working on my blood pressure, and that meant, you know, eating thick foods with less salt and exercising more. And when I came back in, things were looking better. We were able to revise the plan and kind of go for the next step. Also, the slips and the relapse can happen here, but really just affirming the positive changes that had been made to try to keep that person going forward. All right, and then our final stage is maintenance. So action, we consider the 0 to 6 months from when they made the change, and then maintenance is someone who's made the change for more than 6 months and they're just rocking and rolling. So again, affirming those changes and that the maintenance. And then other strategies include really acknowledging that hopefully in most of these cases, someone has made a positive change to their life, and really helping them commit to those changes by affirming the positive impact that that's had on their life. So most of the people that you work with are going to be in the probably pre-contemplation to preparation mode. You know, once people are in action and maintenance, it's really just affirming those changes. But a lot of the work really happens in that contemplation, pre-contemplation preparation stage. Okay, so just real quick, I'm going to do this example, but then we're going to give you guys an opportunity to give some feedback on some examples. So you have a person that comes in and says, I know I should use birth control, but I'm afraid of getting fat. What stage would this be? So it is contemplation. Tammy.
What?
That one word in there. And this isn't a like hard and fast rule, but, and now see, I have a hard time even saying but, because I acknowledge how it impacts what I've said right before. So if someone says, I know I should use birth control, but they're not completely convinced that they should use birth control. They're afraid of getting fat. So again, flipping this on them and saying, okay, so it sounds like you have some concerns about weight gain or side effects from birth control. And at the same time, you are feeling like it might be beneficial for you to start on some birth control. So when you do that flip, it's important that you don't use the but use and, or if that sounds weird for some people, that's hard to just say, you could say, you're afraid of gaining weight on the one hand, and on the other hand, you acknowledge that birth control would be beneficial, or however you phrase it. So again, we know this contemplation because we have that but in there. You can still work with that a lot though. So that is how you would know contemplation. Okay, so now you're gonna get out your phones again and text to the same number that we did at the beginning. But we have a few questions so we can see just where everyone is with these concepts. So what stage?
And this time, I'm sorry, and this time you're going to key in the letter and text in the letter instead of the name
Yes.
of the stage.
Okay. So what stage correlates with getting rid of pantry junk food from December 26th to New Year's, before your New Year's resolution of eating healthy? That ever so popular New Year's resolution. So right off the bat, seems like people got this one. So I'm not going to linger too long because some of these are easier to suss out than others, but I think this one's pretty clear. So let's try another one. Okay, so same scenario. What stage would you be in on January 2nd? Yep, and action, obviously, because you've now started your healthy eating. Oh, well, still got a tie. Now, actually, let's go to the next one, because this one always generates a little bit of conversation. But so the next slide, if a patient told you she does not want children and should probably be on birth control, but wants to think about it more first, what stage is this? Sorry, this wasn't the one I was thinking of, but this is still a good one to answer. Mm-hmm. 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 So I'm thinking with this, and yes, you guys all caught the but in there, I'm sure. This is probably one for this project that we're working on. Between A and B is probably where, just based on my experience, probably where the majority of your clients are going to be with reproductive health or using birth control, especially because we are, the point of the integration is to integrate routine questions into every visit. So a lot of the visits are going to have start with having nothing to do with reproductive and sexual health. And then you ask the questions, the screening questions, and suddenly you determine, oh, this person, again, doesn't want to be pregnant, or you make someone else pregnant, but isn't using any kind of protection. So that could be someone in pre-contemplation, or someone that, is thinking about it, but they don't have time today, they'll come back some other time. So then you've got that contemplation. So I think for the work that you'll be doing with this project, this is most likely where people will be. Does anyone have any other comments or any other observations, especially since you've been doing the screening questions for a little bit now?
Question?
Okay, All right. Tammy, I think the next slide is a duplicate, so we can skip it. Okay. Promise I won't be talking at you very much longer. I only have 3 more slides and then you get to hear from someone else. So now that we've determined, what stage that person is in, of course, you're going to want to talk about, making the behavior change. And really a lot of this is, you're probably going to have already picked up on a lot of things that the client has said that kind of, raise that red flag, not a red flag, it's more of like a light bulb. That says, oh, this person, they are thinking about this, or this is important to them. And so really being able to kind of hone in on what we call change talk and get them to talk more about that. You will probably hear, though, a lot of times someone is still trying to talk themselves into not making a change. Just like, well, I want to eat healthy, but I don't have time to cook meals for myself. I just, I can't exercise. I just don't have the time. So they're sustaining. That was what we would call sustained talk. They're trying to kind of talk themselves into just staying where they are. So it's not that we ignore that. However, we really do want to focus on the change talk. So the change talk, this all comes from motivational interviewing. A lot of what we've been talking about here. We haven't been calling it motivational interviewing because that's a really in-depth training that takes like a week to fully gather, but we're using a lot of the concepts from it. And a lot of the concepts have acronyms, so just that's what we have. So DARN can be an acronym you think about. So if someone says, I want to change, that's showing the desire, or I can change, that's good. They probably have a lot of confidence. It's important to change. And then you might hear a but. So looking somewhere into the reasons, need, I should change. So all of these are things that you had probably heard as you're having this conversation. And now, okay, how do you dive a little bit deeper into that? So we've got another acronym for that called EARS. So someone says something like, I want to change. Okay, well, tell me more about that. Someone says, it's important to change. And saying something like, that's really great that you have acknowledged that this is really important for you. I know that could take a lot of courage. So that's awesome that you're thinking about that. Reflect, I use this one a lot. Anytime you hear someone say, so it sounds like, that's the easiest way to get into a reflection. But, I can change, someone says, and you say, you have a lot of confidence. It sounds like this is something you're ready to do. And then summarize. And this is a skill that, for all of the conversation we've been having is really where the way I think about it, or the way it was taught to me, and I just love this imagery, is, as you're talking with someone, and you're hearing these bits of change talk, and you've heard that they're in that contemplation, but you've kind of talked it out and you've heard more because they've elaborated. This whole time you're like picking these little things that you've heard and making them into a bouquet. And then at the end, you kind of give the bouquet back to the patient. So I heard you say a lot of things today. Let me make sure that I heard correctly and I understand, kind of where you want to go from here. And then you can kind of tick through those different things that you've heard. Okay, so before we move on to the next, I just want to see if there are any questions or again, any examples that the people have where they've used these skills, these strategies, and they found them to really be kind of a moment where things changed with someone. I encourage you to look out for these moments moving forward. We'll definitely have time to talk more about this, but really just kind of, and we'll send out both the recording and the slides after the presentation or the training to really kind of find these moments, maybe thinking 1 or 2 of those strategies that we talked about and integrating them into the work with any kind of client, any kind of a visit, and just see what changes you notice and how patients respond, or how much they open up to you, and then we can always check in on that later. So with that, I'm going to pass it on to Tammy.
Thank you. So now I just want to reiterate what Kara was saying. Now that we've kind of brought this to the forefront of your mind, you may have been trained on this in school years ago like I was, but now that I heard it again, I can remember all the patients that would come in. You can use these strategies with anything, with smoking, weight loss, taking the pills correctly, you know, for blood pressure, just whatever that you have. It's not just related to birth control, because it's really tuning in instead of a yes and no question that, you know, yes, no, and hurrying up and getting out of the room. It's more tuning into what your patients are saying and helping them make a life change that's their idea and how they come up with it, which is more gonna be long lasting than if we try to force anything on anybody. So moving forward, I want to talk about specifically what we call Reproductive Health Integration Initiative is doing in your agency. We are so excited to be partnering with you. This started in January of this year, and what our goal is we know that the wave of the future is FQHCs. That is going to be the patient's home, and what we want to make sure is that you as providers, clinicians, are able to deliver all types of services to your population, which includes reproductive health, birth control, sexual health, pregnancy testing, basic infertility, you know, all these things. So that is what we do is we come in, and for the next 3 years, we're going to wrap you up and teach you how to take care of all things reproductive health to add that to your repertoire of services. There's two things that we need to distinguish. One thing is called FPAR reporting, and that is the actual federal annual report that we have to submit as a state to the federal government, saying how many patients between the age of 15 and 44 that we provided services for. And so you as your agency is going to be providing to us as the program how many patients were screened from the age of 15 to 44 for pregnancy intention and sexual health risk assessment. That's something that Renee can go into you a little further, because we've been working with her for 6 months or so to build out these reports in your EHR. So that's one side, is the reporting side. The actual practice side, what I like to think of is you can do this for anybody regardless of the age. Now, it's mandatory for those in that window of 15 to 44, but if you have a possible sexually active 14-year-old, or as we know, at 44, we don't just all of a sudden stop having sex or needing birth control, right? So you can continue these services thereafter. It's just that we pull the data on this window of patients. So we're going to go into exactly what that looks like and how to perform this in the clinic. One of the things that that I see most with clinicians and clinic staff that we're training is they're a little shy on asking about sex, and I'm just going to tell you that we're not shy about asking about an arm or a leg, but boy, when it comes to sex, we're really tight. So make sure that you get comfortable asking about whatever it is, because this is very important, because it provides high quality, safe, accessible, and effective care all within your organization, where they can come to a one-stop shop and get everything that they need. Sexual history is also prevention as well. So if we talk about how to find and treat STIs, then maybe they won't get a PID that's going to scar them and cause infertility. We can maybe prevent disease burden in the community, and also promote wellness and how to have a healthy sexual and reproductive life. So in taking a sexual history, it improves health. I think we've talked about that. We prevent and treat STIs, HIV, hepatitis, and also help reduce the disease and death among our patients. We identify and treat sexual problems and low sexual satisfaction that can help us improve their mental well-being. And then we show an interest in our patients, not just what we can see, but also the mental and emotional issues that we can't see. So we also improve and with that bond with our patients and our clinicians by truly caring about every aspect of their life. So what we want, the patients actually in a study from the Association of Reproductive Health Professionals and National Women's Healthcare Center, long term, but they found that patients want 73% of the time they're going to be quiet and hope that their provider mentions sexual health. And over 70% of patients actually had a sexual health issue. Now, providers, on the other hand, providers rely on the patients. We sit back and, well, if it's a problem, they're going to mention it to me. But you can see how both entities want the other to mention it, and it's kind of this unspoken issue, and therefore problems don't get resolved, questions don't get resolved. So it is up to us to at least broach the subject, and once we dig in, then a lot of things come to the surface. So who is this for? And the truth is, it's for all of our patients. We can't just assume that if they are with a same-sex partner or a certain gender, race, ethnicity, that they're not going to need that. Or worst case scenario that I've ever seen is, oh, they're married, I don't need to ask them about their sex life or about their sexual risk assessment. That is a huge disservice to the patient. Ask everybody so that we're not putting people in categories of assuming anything about their life.
We wanted to bring up the topic of sex positive to just really ground us in how to talk about this in a way that, like Tammy was saying, is really inclusive of people and practices, with the caveat that the practices are safe and consensual. But we wanted to just see really quick how you all would define sex positive. The working definition that we are going to use, and this is according to the International Society for Sexual Medicine, is having positive attitudes about sex and feeling comfortable with one's own sexual identity and with the sexual behaviors of others. So, just thinking about our own past, our own upbringing, our communities, sex can be a very charged topic. And so we really want to ensure that the patients, the clients that we work with, really can see through our actions, our words, even our physical space, that we're accepting of people regardless of their sex, gender, orientation, identity, expression. And so, and I won't ask for examples here because I think it's kind of hard to get examples from people just in the setting we're in. But really, think of walking into your clinic and just taking a look around and saying, if I was coming here for some sexual or reproductive health service, would I feel that I'm going to be, treated in a dignified, respectful way? A really quick way that you can do this is having like a rainbow flag or the transgender flag, which is like the blue and white one. That way, wordlessly, people who come in who identify as LGBTQIA, if we go the whole way, that they'll know that this is a safe place for them. There are also really great trainings online that can help you kind of work through even things like what your intake forms look like and how questions are worded. Having some concrete strategies for making your workplace inclusive is really important. So this is a graphic I have loved to show for years. Okay, so the gender unicorn, like I said, this is one of my favorite graphics. Sometimes you'll see it as the genderbread man or genderbread person, if we're going to be completely inclusive. So as you can see here, the way that this, what this is describing is that, sex, gender, identity, expression, they all can be kind of distinct pieces of someone's biology and identity, and that it's not entirely a binary. Maybe in the example of sex assigned at birth, although that's not even a binary because we know that people are born intersex, but it's more of a continuum in how people identify. So maybe I identify as, feminine, but I also have some masculine identity in me. Expression, identity is how you think about yourself. Expression is how you show it to the world. So those could be on different ends of the spectrum. And then you have who you're physically attracted to and emotionally attracted to. And again, those may not always match up. It's something we never do, but I always just kind of ask people to kind of do it in their head, is looking at this. If you were to plot yourself on all of these different continuums, what might that look like? And if we were to share that with someone else, I think we'd all have very unique ways of, how we express ourselves. So, I know that this has become just something that's more acknowledged in recent years, that it's not just you're a man or a woman, and you're attracted to either men or women. There's a lot of different ways that people express themselves, and it can change as time goes on. So, just taking this back to when you're working with a patient, trying to avoid any kind of assumptions about how the person you're seeing identifies with themselves, what kind of relationships they have with others, and just really keeping the questions to very open-ended, like, do you have sex? Who do you have sex with? What kind of sex do you have? So that you're able to provide the most accurate care, because it kind of like the situation that Tammy brought up earlier, if someone comes into a place and feels like they're not being respected, it can cause them to not come back or not bring up issues that they wanted to bring up. So really, and again, I know I'm preaching to the choir when it comes to, this patient-centered care, but I also really just love this diagram. So I wanted to share that with you all.
The next topic is going to be talking about the sexual health assessment. So let's say that you just call the patient back to the room. You verified their date of birth and their identity, and you've asked all of the basic questions, like all of their history, their family history, social history, and now it's time to start into the sexual health assessment. How do you introduce the discussion about sexual health to your patient? Do you say, okay, Katie, bar the door, here it comes. This is going to be personal and it's embarrassing, and I'm sorry I have to do this, but I have to do this with everybody. Do you see what we've just done there? Not only does it reveal how uncomfortable we as providers are or clinicians are, it's done made this person uncomfortable, like, oh Lord, what are they supposed to ask me? This is going to be bad. So I'm going to give you a couple of ways to introduce this. So it not only, after doing this for a while, it's going to boost your confidence, but it's also going to put that patient at ease as well. So a couple of the things that you want to make sure in your statement, you can devise your statement for however you want it, but make sure they know this is personal. It is confidential. It's important. And I ask everybody these same questions. It's my standard of care to make sure you are getting the best care possible. Okay? And so some examples of some opening statements. At this clinic, we ask a lot of questions. Questions about your medical history, drugs, alcohol, and sexual history. Everything I ask is confidential. And I ask all my patients these questions so I will know what test you may need today and what places on your body may need to be tested. I'll also be asking about some personal questions about your sexual health. I ask these of all my patients. Everything is confidential and will help me to take care of you today. May we continue? And so whatever is most comfortable to you is what you need to go for. Or you can make up your own. Just make sure it's got those it's confidential, it's personal, it's your standard of care type bubbles. Okay. So once you've introduced it, there are 5 P's according to CDC that we need to go over. And if you just do the sexual history, inside the sexual history is also your pregnancy intention. So really, It's just doing the 5 Ps. The 5 Ps are stand for partners, practices, past history of STIs, pregnancy, and protection from STIs. Partners. Okay, warning, make sure that you stay gender neutral when you are asking about partners. If they are a female coming in requesting birth control, don't assume they are only with a man. They may be with both. So we need to ask the patient, tell me about your partners. We want to know how many partners in the last 2 months and how many in the last year. So the first question about partners in the last 2 months tells us, is there high risk in the last 2 months that isn't consistent with the last year? 2 partners in the last 2 months, but 50 in the last year, then I'm wanting to know what's happened in the last 2 months to make them go from 50 to only 2. You know, what has changed in their life? Also, is any of their partners symptomatic? Do they have any discharge? Do they have any pain? Do they have burning when you urinate? Any of that? And then is it possible that their partners may have other partners? So some examples of how to ask this question. The first one is, what gender are your partners? Male, female, trans, female, trans, male, or both? Now, truly, in my practice, I typically went with B. Some people have sex with men, some people with women, and some with both. Who do you have sex with? That gives the buffet, and then they get to choose and let you know what their practices are or partners are. Do you have sex with men, women, or both? That's an easy, concise one. Is what it is, and again, they get to pick. So you can pick your own, what you're most comfortable with. Let's talk a little bit about sexual practices. When we ask about sexual practices, we want to find out what types of sex and locations of sex they're having. For oral and anal, it's important that we find out, are they giving or receiving or both? We want to know about condom use with each type. So many times what we find is that they will say, do you use a condom? Yes or no. But we really need to ask, do you use a condom with vaginal sex? Do you use a condom with oral sex? Do you use a condom with anal sex? Because if they don't, that could increase their risk for certain STIs in other places. When a patient says that they, the sites that they have sex are vaginal, anal, and oral, then we're doing gonorrhea, chlamydia testing in all of those sites. The CDC has now changed their STI guidelines coming out in 2021 to recommend that both men and women are screened in all locations of site. So not only does this need to be asked of MSM, but of all, and just let them know that we need to test for gonorrhea and chlamydia in whatever area that they have been possibly exposed. So many people have different types of sex. What kind of sex have you had in the past 3 months? What kind of sex do you have? That to me is a little more ambiguous. I like the third one. There are different ways to have sex, vaginal, oral, and anal, and you can get infections in different parts of your body. Let's begin with vaginal sex. When was the last time you had vaginal sex? So if you assume, go ahead and just lay it out there like you're assuming they are positive for all 3. They'll say, oh, I don't do that. But when you say, have you ever had this, this, and this, there's still a social stigma with oral and anal sex because the society views that as not normal, whatever. Let me just tell you right now, whatever is consensual between partners is normal. If that's what they want, then we can't label it as abnormal. Kara has a statement, don't yuck my yum. And I love that statement because what may not be for me doesn't mean that it's not for someone else. And we need to treat that person and make sure that we're testing in the right areas. So for me, it's the third one. The other reason that I like the third one is I'm not trying to get in your business. I'm not trying to get in your bedroom. I'm not trying to judge you based on what you do. I'm explaining that the reason why I need to know this is because I need to know what areas to test. So that also gives them a reason behind my question. There's a couple of other questions that you may want to ask about practices and partners, like when was the last time you were drunk or high when you had sex? That any time that they're using alcohol or drugs and making those decisions, they can be less apt to use the correct protection. So it may increase their risk a bit. What is your experience with party and injection drug use, and about your your partner's experience with party and injection drugs? Also decreases the inhibitions. Have you ever had an experience where you had to trade sex for something you needed? And of course, the last is partner history of HIV, injection drug use, or hemophilia, because we cannot forget that we have pre-exposure prophylaxis, or what called PrEP, and then post-exposure prophylaxis, which is PEP. And we have, I'm sure that you have in your community providers that offer that, but if not, we definitely have a teleprep program for the state that could make sure that those patients get those services. Past history of STIs, actually, I have STDs, but it's now moving to STIs, which is great. What STIs have you had in the past? So if you say, Kara, what STIs have you had in the past? She's going to say blah, blah, blah. But if you say, Kara, have you ever had any STIs in the past? Then you see how that different, they're going to be like, no, no, no. But what STIs puts it in a different frame. What STIs have your partner had? And then when was your last STI test? So just one word can change it from being more inclusive to more of a judgment.
And prevention and or protection, this really kind of gets at that the screening question. I know we had the screening questions worded a certain way, and I believe we had said, you know, what do you and your partner do to prevent diseases that can, or infections that can be spread through like sexual activity. It's a very wordy way of putting it, but basically you're trying to get at through that specific screening question, you know, could this person use some either education about how to protect and prevent STIs? Do they need tests? Do they need treatment? So it kind of like what we were saying before with the questions, you can put it in words that work for you. But you really were trying to get at, has this person had unprotected sex with partners that they didn't know the partner's STI status? Do they need help using condoms? You know, what can we provide for that patient that is going to help them be able to prevent STIs and unintended pregnancies and protect their partners? So this is the time that we're going to do something that I love to do. I have done it probably hundreds of times. You may all have done this too, but I wanted to just do a condom demonstration because if you've ever put on a condom in any form, it seems pretty straightforward. As long as you're making sure you're putting it on the right way and you know it doesn't break or anything, it seems pretty straightforward. But back when I used to work for Tulane University, we had this poster that we would put out. It was the 22 steps of using a condom. Now that definitely stretched it out a lot more, really detailed. But I wanted to just go through the many, many steps that there are, because I feel like there are a lot of really good talking points all along the way. And even if you've done it before, maybe you'll learn something new. So we're going to go ahead and do that. So when I start with my condom demonstration, I'm going to try to anchor myself so you can see the demonstrator. And this is a very special demonstrator. I was in the Peace Corps in Madagascar, and this was the wooden demonstrator I used when I did these on the other side of the world. when talking about condom use, and unfortunately I was going to do a internal condom demonstration as well as an external. This is what we would call external, but I didn't have any internal condoms, so we'll have to save that for a later date. So right now we're just going to be talking about the external condom. The first thing I like to talk about is the idea of consent. So when you say, what's the first step in using a condom? It's to get consent from your partner, your partners. And that's enthusiastic and it's ongoing. It can be withdrawn at any time. But say you and your partner have consented and you've talked about the fact that you want to use condoms. You've got to get yourself a condom. So people have different preferences when it comes to condoms. So if someone ever tells you, oh, I tried condoms once and I just don't like them. It could be that brand, it could be the fit, you know, there are different sizes, the texture, maybe they used a flavored condom for vaginal sex and got a yeast infection, because you don't want to be using flavored condoms for vaginal sex. So there's a lot of different ways that could have gone wrong to sour that person on using condoms at all. So to really encourage people, we'll try a couple different kinds. You know, maybe you'll find that brand that works best for you. So we've decided we're using Lifestyle. You'll want to make sure that the condom is in good shape in terms of it hasn't been sitting in a car, you know, glove compartment or, you know, in someone's wallet. I mean, even bumping around in someone's purse, you know, it could have bumped up against something sharp. So you want to make sure that you feel that it has a little bubble in it, which will tell you that it wasn't punctured, hopefully. You want to check the expiration date. So I already looked at this one and we're getting in under the wire. It expires in June. Usually you'll want, you know, condoms that are expiring a little bit later out, but that's the one I had. So, okay, so we've got our condom. We need to open the package. Teeth may look really sexy in the movies, but they could also damage your condom. So don't use your teeth. You really just push the condom over to the side. It's got those little ribs that you can open it up and you're good to go. Okay, so now we need to make sure that we're putting the condom on the correct way. Because if you start putting it on one way, if there is, you know, pre-cum, you could get that on the condom, and then if you flip it, you've kind of, you know, negated the reason for using your condom. So we're going to pull it out, and we're going to look for the sombrero, not the beanie. So the sombrero, I don't know if you can see, it's where the condom rolls outward. The beanie was where it would roll inward. So you want to make sure it's the sombrero, not the beanie. This can be a little bit harder to do in the dark. So if you're working with someone who's maybe new to using condoms, asking them to try it a few times, you know, without looking to see it, because you can feel this too, to make sure that even if it's dark, the person's putting the condom on correctly. Okay, then you're going to pinch the tip of the condom. You can, for a little extra, you know, zhuzh, put some lubricant on the inside, just at the very, very tip, because then that would allow for a little extra movement, but not the rest of it because you don't want it to slide off. So you pinch the tip, and then and that's to allow for the ejaculate so that it doesn't, you know, burst at the top, and then roll all the way down to the base. I say the more lube, the better, because that's going to help you prevent some breakage. You know, if you do have someone that's coming to you and they're saying, I've used condoms, but every time I use them, they break. So I would ask about, okay, are you pinching the tip? Are you using enough lube? Does it fit correctly? Because you can also have, you know, a situation where the condom isn't big enough. You can have other situations where the condom is too big. If you find that someone keeps saying, well, it keeps like sliding off inside of my partner, maybe we need to talk about a snugger fit condom, which exists. So anyway, then you have your sex, you have sexy time. And then while the penis is still erect, pull out, and then very carefully remove the condom and dispose of in a proper place. So not in a toilet, not in a wastebasket if you have small children or pets that might want to get into that. Tie it in a knot and dispose of it, like I said, in a safe spot. Now, to be extra careful, whoever's just taken the condom off, you know, you're gonna have now fluids on your hand from your partner. Make sure you wash your hands before touching yourself or touching anywhere else. Also really important if you're going between anal sex and vaginal sex, specifically in that direction, to take off the condom and use a new condom because that can cause infections. And the condoms can be used for oral sex as well. I mean, people seem to have a lot of resistance to that, but especially if you know, one situation that I always tell people about is if you know you have oral herpes and you want to provide oral sex to your partner, you can transmit it that way. And so a condom would be a great way to have your fun while also trying to keep safe from something like that. And of course, as Tammy was talking before, we know that chlamydia and gonorrhea are showing up in, in the oral area. So really condoms for barrier methods, I should say more specifically, for any situation where body parts, especially with the more sensitive mucous membranes and fluids could possibly come into contact. Like I said, I don't have the internal condom, but I did just want to say a few words about that. So it's been known in the past as FC2 or the female condom, but in reality, it can also be worn in the rectum for anal sex. I've got the word. So that is something, when you're talking to your partners about the kind, or your patients about the kind of sex they're having, if you have someone that's like, yeah, I don't use condoms with my partner because he refuses to use one when we have anal sex, you can say, well, the great thing is you can use it. So again, it can be worn vaginally and anally. If it's worn in the rectum, you'll want to remove the little ring that's inside of it. But the nice thing about that method, whoever is the partner wearing it, after sex, you can still have some, post-coital time together without having to, like you would with an external condom, immediately get up and like clean things up. You have a little bit more time to just, chill, enjoy the afterglow. And the other thing I would say about it too, one thing I've heard many times from people that say that they don't like condoms, they don't wear condoms, they'll say, I have an allergy. And it is very possible that the person has a latex allergy. There are other materials that are used for condoms. Anything except like natural materials like lambskin, those would not protect against HIV. They could protect against pregnancy, but the pores are too big for preventing HIV. So talk to your patients about the different options that are out there. Again, though, with the allergy, unless they absolutely know it's a latex allergy, it might have been something else, like the lube that was used or something else, or that there was no lube used. That's a big one. Sometimes people don't know that some condoms come unlubed and you need to add extra lube.
So there was a couple things I wanted to tag on, and this is like, I always go back to the real world, right? So a patient comes in and they say, well, my partner won't wear condoms because he doesn't feel anything. Have y'all ever heard that? Shake your heads, yes. Okay, so I see y'all shaking your heads. So one of the things, a tip or trick, there's two of them that I can think of that Kara has actually taught me that I didn't know before, was when you put a little dab of lube inside that condom, it glides over the head of the penis. And so when we're thinking about the anatomy and physiology and the makeup of the glands of the penis, we also know that is equal to the clitoris of a woman and where all of the nerve endings are. So the more we can increase that lubrication around that glands, the more that they're going to feel. So that might be something you might want to ask the patient. Has your partner or have you ever put a little bit of lube inside the tip end of the condom so that it will glide easier? We find that can increase enjoyment, because I mean the whole thing around it is we got to enjoy sex, right? So that's one of the things. The other thing is the FC2 or the internal condom. A couple things. So it's paid for through a prescription. So the provider can write a prescription for FC2 and they can have them on hand. If you think that you're going to have sex, you can put this in the vagina hours before. And it's got that ring that's almost the size of a Nuva ring. And once you squeeze it and you put it in the vagina, it opens up and it stays behind that pubic bone. Now the external ring is going to hang out. That's okay, but there's a couple reasons for that. That's kind of good. So the first thing is if you put it in ahead of time, that polyethylene warms up to the body. And instead of you putting it in like right before sex, and then it sounds like you're having sex with a trash bag in the vagina, if it warms up to the body, it allows a lot more pliability, and it doesn't make those noises. So that would be my recommendation. If your partner won't, then put that in ahead of time. And then as it warms up to the body, and then as your partner goes in, you will hold the external ring and make sure that he goes in the middle of the ring. There's also something called, what is that called? Where they move it over to the side. Penile misdirection. I don't think that's an accident, but as a female, we're going to want to hold that in place and make sure he goes in the center so that, he's not messing us up. The other thing with that ring hanging on the outside is it's just big enough to get a little bit of clitoral stimulation at the same time that we're getting vaginal stimulation. So it's not a bad thing. So some of your female patients may want to say, okay, let me try it, because the whole idea is we need to be as safe as possible, but we also need to make it enjoyable. And if it ain't enjoyable, they're not going to use it.
You just want to make sure that someone is not using 2 condoms at the same time, or the internal and the external at the same time, because that can cause friction. And then finally, I would just say, for people that are new to using condoms, having them practice outside of a sex situation so that they know how to put them on, they know how to take them off, especially with that internal condom, because it's really slippery. So it takes some getting used to. So just encouraging them, before you actually get in that situation, number one, make sure you have that protection so you're not scrambling at the last minute or deciding, oh, we don't need it. So just carrying something with you and, being prepared for the possibility, and then practice makes perfect.
Has anybody done a condom demonstration to an adolescent? I would recommend having a condom demonstrator, one for vaginal and one for penile as well, because it's a game changer. You bring that out and initially they're embarrassed, but then they want to know all about it. So it's a game. They think they know how to use a condom, and then they come in, they say it's breaking. They don't know how to use a condom because they're leaving the air at the tip, and then it explodes. It falls off. They're getting the wrong size. Not everybody's a Magnum. I'm sorry. Anyway. All right.
Okay, so this will wrap up our 5 Ps, and then we have a great video to watch. So the last P that we're going to talk about is pregnancy. So again, we know this is one of our screening questions, and I think the way that we've had it worded before is, what are you and your partner doing to prevent pregnancy, or I'm sorry, that's the sexual health question. Are you or your partner planning a pregnancy in the next 12 months? Something to that effect. And you can see here, there again, some different ways to ask it. Your current plans, are you trying? What kind of birth control have you used? What would you consider? There is another way, though, that is fairly new that we wanted to introduce you all to, and then we'll have the video that demonstrates it, which I think is really awesome, is the PATH approach. So this, using the questions in this way, really gets you the information you need pretty quickly. So PATH stands for pregnancy attitudes, timing, and how important is pregnancy prevention. So let's see what that looks like. You'd first ask, are you or your partner, what is that question? Do you think you might like to have a child or more children at some point? So you're probably going to get a yes or no to that. Some people may still be ambivalent, so you may have some the maybes in there. If someone says yes, then get a sense from them when that might be. So if it's, a month from now, or we're trying right now, that's one kind of conversation. If it's like, oh no, I mean, sometime in the future, but I want to, work a few more years at my job, or, graduate, or whatever the case may be, that gives you another, set of information that you can use to help kind of guide this person to methods that might work for them at this point in their life. So that's where you get to that, how important is it to prevent pregnancy until then? Now, this, I think, was the game changer with this method, because a lot of I think there was a lot of assumption going on that if you weren't planning a pregnancy and you got pregnant, it's unintended or it's unwanted. And there actually have been some great studies out there that show that for some people, they like to leave it up to chance. You know, I'm not planning a pregnancy, but if it happened, I'd be okay with that. Or, you know, there's some different ways to answer that. So rather than just assuming that if you don't want to get pregnant now, then you have to use a method, otherwise, like, doesn't make sense, really get at the how important. So it gives them a chance to maybe think about it in that moment, like, oh, if I did get pregnant, that may not be best for me right now. So yeah, let's talk about something. And this will really get you into then what contraceptive methods might work for this person in this moment. If they say, definitely not for the next 5 years, great opportunity to talk about long-acting reversible contraception. If they're like, well, I have this big project I'm working on, so definitely not for the next 6 months, that may be another method. You know, you'll also, as you start to transition into the contraceptive method conversation, which, as a reminder, we still have that birth control 101 training up and available for anyone. If anyone didn't get a chance to watch that before, we'll make sure you have the link to that again. But it allows you then to kind of transition into, okay, well, you know, here are the different options that might work for the current situation you're in, and asking some more guiding questions to kind of hone in on the method that works best. So like I said, we have a video. I'm really hoping this works because this video really takes you through. We wanted it to be more of a global, all of the 5 Ps, but it really does focus in on the pregnancy prevention piece of it. But it also pulls in a lot of what we were talking about earlier with the change talk, the stages of change. So this is going to be our summary for pretty much everything we've done so far. So Tammy, let's hope this works.
Can I just mention one thing about how I do this, like in practice, is, you know, as you go through the path and say the patient does not want children now for the next at least couple years, and then we find out, no, it's really important for me to prevent pregnancy until I've graduated college, or whatever they say, then in my brain, if you'll just allow me for a moment, in my brain there is a row of boxes, and all of those boxes are open. Okay, and so as they're talking to me through this path, I'm shutting boxes of those methods that may not be the best for them. For instance, if they want long-term coverage, I'm probably keeping the long-acting reversible contraceptives open. I'm keeping the depot option open. I'm keeping the pills open, you know, that kind of stuff. But let's say that they want a baby, or they want to try for a baby maybe in 6 months. Okay, so then I'm kind of, it's not that I'm shutting them all the way, but that's the long acting is probably not going to be my number one choice. Depot for sure not, because it can take a year to wear off. So then we're looking at, you know, these methods that are quickly reversible. So that's kind of the way my brain works as I'm going through this, is these boxes shutting as they, or opening as they tell me more, you know. And then it, instead of you showing up and throwing up all of these different methods that can overwhelm a patient, you can zero in on what may be the best method for them, and give them a couple options instead of 10, which is gonna freak them out.
This is used for your pregnancy planning, not necessarily prevention, because you're going to hear things through asking these questions that indicate that person is trying, or maybe they're not, they don't want to get pregnant for a year, but that's a great opportunity to talk to them about prenatal care and really preparing their bodies and their health for a really healthy pregnancy. So, you know, this, I think it's just a really great way of doing this, because it helps you kind of just get to know more about the patient, what their plan is, so that you can provide, you know, the most appropriate care.
The following videos demonstrate how to operationalize patient-centered counseling about reproductive goals and contraceptive preferences
Can you hear?
using the PATH framework. This framework is a concrete set of open-ended questions and counseling skills
Give me
designed
a
to
thumbs
effectively
up or
engage
thumbs
with
down. Can
patients
you hear?
about their reproductive goals and, when appropriate, pre-pregnancy care, contraception, and infertility services. PATH is an acronym. The PA stands for parenting or pregnancy attitudes, the T for timing, and the H for how important it is to prevent pregnancy. PATH asks the following 3 questions. For the PA, do you think you might like to have children at some point? Or if the person's already had children, do you think you might like to have more children at some point? The T, when do you think that might be? And the H, how important is it to you to prevent pregnancy until then?
Just before the scene begins, we come into a visit that has already started. Patty asks the first PATH question, and notice she doesn't ask the T in PATH, which is the timing-based question, when do you think that might be? She does this because Mia has already said she doesn't see that happening anytime soon. If she had asked the T question, it would show Mia she wasn't listening. Notice Patty's facial expression when Mia expresses joy at the thought of being a mom. Finally, notice that when Patty asks the last question, H, how important, she includes what Mia had said and asks, how important is it to you to prevent pregnancy until you're married?
So do you think you might like to have children at some point?
Oh yeah, I would love to be a mom someday. But I'm really traditional and family's really important to me. I want to be married first, and I don't really see that happening anytime soon.
How important is it to you to prevent pregnancy until you're married?
It's really important. But, things happen for reasons, so if it happens, I'll deal with it.
So since you've said you don't want to be pregnant anytime soon, would it be helpful to talk about options for contraception?
Yeah, that sounds great.
Great.
Patty transitions to offer a discussion of contraception based on paraphrasing what Mia has said, and then asks, do you have a sense of what's important to you about your birth control? Mia asks what she means, so Patty gives examples. If Mia had not asked, Patty would have given her 5 seconds to consider the question before rushing in with examples.
Do you have a sense of what's important to you about your birth control?
I'm not sure what you mean.
For example, some birth control methods are more effective than others. They do a better job at protecting you from pregnancy.
Patty uses a visual aid during the examples. Notice the plain language. Some methods change the way your periods come. Then, after she gives examples, Patty asks a follow-up question. Is any of that important to you?
Some methods have hormones in them and some don't. Some methods will change the way your periods come and others won't. Is any of that important to you?
Yeah, when I was looking at this chart, I was just surprised at how differently they all work. I guess I would want whatever works best.
Patty paraphrases using plain language. She incorporates the patient's priorities until you're married, and then asks, do you have a sense of what else you're looking for?
So you really like something that's great at preventing pregnancy until you're married. Do you have a sense of what else you're looking for?
Something natural, without hormones.
Patty doesn't ask why Mia doesn't want hormones. Patty starts with validation and then respectfully asks for more information. Can you help me understand what is concerning to you about hormones? So if Mia's objection had been based on misinformation, she could have addressed it.
I hear that a lot. And different people have a variety of different things that are concerning to them about hormones. And I'm wondering, can you help me understand what's concerning to you about hormones?
I don't want anything that'll disrupt my body's natural rhythms. I try to take care of myself, and I just don't want to put anything unnatural in my body.
It sounds like you'd really be more comfortable with something that's hormone-free.
Yes. So far, I've been using condoms, but I don't really like how they feel. When I first start dating somebody, we'll use them until we get tested. I know it's really important to protect against STDs.
Patty validates, then gives information, then points out something very positive. You can see Mia is happy that Patty sees her for who she is. Patty then paraphrases, and when Mia corrects her, she is not defensive and welcomes the clarification. thus increasing rapport while further clarifying Mia's preferences.
Yeah, condoms are a wonderful way to protect yourself against sexually transmitted diseases. And it's an example of what you were talking about taking really good care of yourself, that you're so responsible about getting tested.
Been doing pretty good so far.
So it looks like you're looking for a method that has no hormones and that's really reliable. Do I have that right?
Yes, and that's natural.
Right. Thank you for clarifying. And when you say natural,
Well, like you said, some birth control changes your periods, and I like getting my period. I mean, I like knowing what's going on with my body. So, just being natural.
Patty uses a tactile aid which Mia holds while Patty gives only 2 pieces of information.
well, this IUD contains no hormones. And as you can see, it's up here at the top of this chart that you were looking at. So it's one of the most effective methods that we have. This is what it looks and feels like.
But don't these mess with your ability to get pregnant later? I thought I read that online somewhere.
Patty starts with positive agreement and then goes on to clarify, rather than correcting Mia or chastising her for believing misinformation online. Patty goes on to make a recommendation for a trusted internet source. She gives a personalized recommendation for bedsider, and only then does she explain the correct information.
I think what you're talking about is the shot. And it could take a while for somebody's natural ability to get pregnant to come back after they stop using it.
I read a lot, sometimes too much.
While I'm thinking about it, there's a website that I think you might really love. Since you like to look things up and you like to keep yourself informed, it's called bedsider.org. And it's all about contraception, and the information on there is all accurate. And it's really actually very fun. This chart that you've been looking at comes from that website.
Oh, great. Well, thanks. I'll check it out.
Yeah, let me know what you think. And just to be clear, all the other methods of birth control, except the shot, once you stop using them, your ability to get pregnant goes back to whatever's normal for you immediately. So you've been really clear that you want to be a mom someday, but that it's important to you not to get pregnant until then.
Patty uses the words up to 10 years to emphasize that Mia doesn't have to use the device for any particular length of time. She adds another phrase that underlines the idea that Mia does not have to use it for the full 10 years and emphasizes the concept that she will remove it anytime Mia wants it out. Patty uses plain language with the phrase, "Your ability to get pregnant goes back to whatever is normal for you immediately," rather than saying, "return to fertility," or telling Mia that she can get pregnant immediately.
And this IUD will work for up to 10 years. But if you'd like to get pregnant at any point before that, or if you'd like it out for any reason, just come in and we'll take it out for you. And then your ability to get pregnant will go back to whatever's normal for you immediately.
Oh, I really hope I don't need it for 10 years. I want to be married before then.
Just as long as you know that you can use it as little or as much time as you like, up to 10 years.
Patty offers to discuss side effects, which is something patients want their provider to tell them about. She then gives only 2 pieces of relevant information and then asks a follow-up question. Notice other times when Patty asks a follow-up question after telling Mia something. This is so Mia can digest the information she has been given and she is not overloaded with information. Notice Patty's hand motions as visual aids.
I imagine you'd like to hear about side effects?
Please, this sounds too good to be true.
So because this copper IUD has no hormones in it, as we said, women will continue to get their natural period, just like they would if they weren't using any birth control. Some women may have heavier periods or longer periods or have more cramps. What are your periods like now?
They're normal, I guess. Sometimes I have to use a heating pad, and that helps.
And you've been pretty clear you don't want to use any hormones. And I'm just wondering if you would be uncomfortable using medication if you got a headache or pain of some kind?
I mean, if I need to, I'll take a leave. Not the name brand, the generic kind.
That medication, generic Aleve, is called naproxen sodium. And actually, if you use it when you get your period, when you're using the copper IUD, it can reduce the amount of bleeding that you get by more than half. Do you usually know when your periods are coming on?
Yeah, a couple days before I'll get a backache, and so that's why I use the heating pad, and my breasts get really heavy and sore.
Patty empathizes before moving on to give more information. Notice that she neither overreacts nor underreacts. Empathy is best displayed without labeling someone's emotions and matching the level of emotion. In this case, there is minimal emotion from Mia, so Patty matches it.
That sounds uncomfortable. So the medication that we're talking about actually can also help with your backache and any cramping that you get.
Oh, that's even better.
So if you want to try this, then what I would suggest.
Patty personalizes the instructions to Mia by including Mia's particular premenstrual symptoms. Patty offers to write a prescription sensitive to the possibility that for some people, prescriptions are less costly than over-the-counter medication.
When your period's coming on, and you know that your period's coming on, you can feel your backache, start taking the naproxen sodium. On the package, it'll say 1 tablet in the morning, 1 in the evening with food. Just double that, 2 in the morning and 2 in the evening.
Okay, got it. But is it okay to take that much?
Yeah, actually, that's the prescription dose. And if you prefer, I can write you a prescription.
Oh, actually, that would be great. It would actually be easier and cheaper for me since my prescriptions are paid for.
Great.
Patty uses teach back, but takes the responsibility on herself by saying, "So I've been as clear as I could be," or "to be sure I haven't left anything out," instead of asking Mia to repeat back what she just told her in order to check that Mia heard and understood, which could make Mia feel patronized.
So we've gone over just a ton of information today, and I want to be sure I've been as clear as I can possibly be and haven't left anything out. Can you tell me how you're going to reduce bleeding when you use the copper IUD?
Is that it, Kara? Or do I need to keep it going?
Yeah, no, I would love for everyone to see the credits because there are some great people that work but we don't have to.
And we can also give you this link if you want to watch it again. Is there stuff after the credits, Kara? Okay. All right.
So normally we would facilitate a conversation about what we saw in the video, but the thing that I really like about this video is it facilitates itself as it goes along. Really gives you a chance to see all of the different ways, communication styles that the practitioner is using to help this person on their journey to finding a reproductive health contraceptive method that works for them. So the body language and her facial expressions, she really was matching what Mia was, how she was being present, and not overreacting or assuming anything, but really just kind of matching that patient's vibes. Sometimes you will get patients, and I know you've had them before, where they are a little bit more amped up. So you can also use your body language to kind of just smooth that down a little bit. Sometimes even just backing up a little bit to kind of show that calm can really help de-escalate someone if they've got a little bit amped up. And then of course her word choices, her tone, it was really just a very skillful. You can tell that that woman is actually a nurse practitioner because she was really able to reflect what the patient was saying and sprinkle it with the reflections and then providing information, asking open-ended questions, really using the full range of skills that we've been talking about today. So just to sum those up, when you're talking about sexual health, really kind of evaluate your own communication style. This is the next slide, Tim. Again, the open-ended questions are going to go really far. It may seem like they take extra time, but again, if you use open-ended questions and listen, you're often going to get a lot of the information that you could have gotten by yes/no answers. So, but it gives the patient more time to put it in their own context. You want to suspend judgment. Again, I know that's something that you all are fully capable of doing. And then using the normalizing phrases. So really saying, oh yeah, I've heard that from a lot of people. That's pretty common. Really kind of going back to what Tammy said earlier, which I think is really important. When you're introducing the sexual health assessment just in general, normalizing it. It can be tempting, especially when it's something new, and if it is something that's uncomfortable for you to talk about, if you start out with that, okay, we know this is going to be weird, but we got to do it. That really is setting the tone. So making it normal, like we do this with everyone, this is just part of our practice, is really going to go a long way with that rapport building